So from the abdominal part of esophagus, it will drain in turn into celiac nodes. Okay, so that is about B part. Next, coming to the C part. The C part of abdomen will drain into the right gastroepiploic nodes. Okay, right gastroepiploic nodes, and this in turn will drain into subpyloric nodes. Okay, from subpyloric nodes it will drain to hepatic nodes. So it's somewhat a longer pathway for the C. From the hepatic nodes it will drain into again celiac nodes. So if you see anywhere, the celiac nodes is like an end point. So next, coming to the D type of D part of the abdomen, it will first drain into, actually it has many routes, like of course mainly 3 routes. It can either drain into pyloric nodes or into hepatic nodes, okay, or into left gastric nodes. So this is like a route of D type. Okay, so finally, if you observe all the stems, the main types are pancreatico-splenic nodes, right gastroepiploic nodes, pyloric nodes, left gastric nodes. So this all nodes, if you see, they pass through the intestinal lymph nodes. So finally all these lymph nodes need to pass by intestinal lymph trunk. Okay, so from intestinal lymph trunk finally they'll reach the cisterna chyli. Okay, so this is the route of lymph drainage in abdomen. So next we'll discuss about the nerve supply. So in this in this page we are completely about the blood supply, both about arteries and veins of stomach, and here we have discussed about lymphatic drainage of stomach. Now let us start the nerve supply of stomach. Actually, nerve supply of stomach is divided into sympathetic and parasympathetic nerves. So mainly the sympathetic nerves are derived from T6 to T10 segments of thoracic region of spinal cord by means of greater splanchnic nerves. Okay, by means of greater splanchnic nerve, and also by celiac and hepatic plexus. Okay, by means of greater splanchnic nerve, celiac and hepatic plexus, T6 to T10, the sympathetic fibers are arising. Okay, and they're traveling along on the arteries to supply the stomach. So mainly this type of nerves are vasomotor, motor to pyloric sphincter, and inhibitory to rest of gastric musculature, and they're like a chief pathway for pain sensation from the stomach, that is sympathetic. Now coming to parasympathetic, they are derived from vagus. Okay, vagus. Okay, through mainly they are coming from esophageal plexus, by esophageal plus esophageal plexus and gastric nerves. And especially now let us draw a diagram for the parasympathetic nerves. Okay, so again the same stomach, this time let us try to draw it neatly, somewhat neatly. So first comes anterior gastric nerve, and it gives one branch to pyloric branch. This is called pyloric branch, and this is first our anterior gastric nerve. Okay, so actually anterior gastric nerve is made up of either one or two trunks. It mainly contains left vagal fibers. Okay, it mainly contains left vagal fibers. Okay, next coming to posterior gastric nerve, let us draw it. So this is posterior gastric nerve. It gives one branch, that is celiac branch, and that celiac branch in turn will form like this. This is the celiac ganglion. Okay, so posterior gastric nerve is again made up of one or two trunks. So it mainly contains right vagal fibers. So where we are drawn posterior, this is posterior. So it mainly contains right vagal fibers. So one thing you need to remember, anterior gastric nerve have left vagal fibers. Posterior gastric nerve have right vagal fibers. This is important to remember. And anterior gastric nerve will divide into number of gastric branches that we have discussed. Especially anterior gastric nerve supplies the fundus and body of stomach and also gives one branch to pyloric branch. Like especially it gives two pyloric branches, one for the pyloric antrum and another for the pylorus. Next, coming to posterior gastric nerve, it will divide into smaller gastric branches for posterior surface. According to the name, posterior gastric nerve supplies the posterior surface of fundus and body and also pyloric antrum. Next, coming to celiac branches, as we discussed, the largest celiac branch for the celiac plexus, sympathetic nerves are motor and secretomotor to the stomach. So the stimulators cause increased motility of stomach and secretion of gastric juice, like which is rich in pepsin and HCl. That's it. So this is like very simple. We are completed about the nerve supply. So next thing we need to see what is the functions of stomach. Okay. So this is like very simple again. Everyone knows the functions of stomach. Primarily it is a reservoir for food. Okay. So it is a reservoir for what? Food. Next comes peristaltic movements. It softens and mixes food with gastric movements, right? So peristaltic movement. Next comes gastric glands, which produce gastric juices, right? Which play important role in digestion. So comes next one is gastric glands for digestion, right? And next you have lining cells of stomach, which produce abundant mucus and protects the gastric mucosa against corrosive action of HCl, right? So next comes gastric mucosa lining. Okay, gastric mucosa lining, protection against HCl. Next is some substances like alcohol, water, salt, few drugs absorbed in stomach, right? So you can write few drugs absorbed in stomach. Next, coming to stomach produces intrinsic factor. Yeah, this is important. Stomach produces intrinsic factor, or you can say casal, which helps in absorption of vitamin B12. Okay, so these are like some important functions of stomach. Now let us complete this session by means of clinical anatomy. Okay, so in the clinical anatomy, the first point is gastric pain. Gastric pain is mainly felt in epigastrium because it is supplied by the roots of T6 to T10. So gastric pain is felt at epigastrium because it supplies up T6, the segment which is supplying it is T6 to T10 of spinal cord. Even the same T6 to T10 also supplies the abdominal wall. That is the reason why you get the pain in the epigastrium or the abdominal wall, or like there are like some spasms or local spasms can be there, right? Whereas in the case of ulcer pain, if you have ulcer pain, there's a local spasm only, local spasm irritation. This is the characteristic feature of ulcer pain. Next, coming to second clinical, that is skiagram. So actually we use skiagram after giving a barium meal. So if you give barium meal, you can do a skiagram and check out the stomach, like what is going on in it. And mainly you can also use a gastroscope. Okay, use gastroscope. It is passed into stomach by means of mouth. So these are like the methods by which we can evaluate the abdomen. Next, coming to third point is about peptic ulcer. Peptic ulcer mainly occurs in the sites of pepsin and hydrochloric acid, namely the stomach, first part of duodenum. So where the peptic ulcer may occur, so let us see this one. So peptic ulcer may take place in stomach, first part of duodenum, and in lower end of esophagus, plus Meckel's diverticulum. So these are the sites where you have a chance for ulcer, peptic ulcer. Okay. And next, coming to gastric ulcer. Gastric ulcer is common in lesser curvature of stomach. Why lesser curvature? Many reasons are like it has less blood supply, it is very thin, most of the fluids we drink go directly over there, and nerve supply is more with large ganglia, and it is shorter wavelength. So many reasons you have for this, you can check out. Okay, so gastric ulcer most common in lesser curvature of stomach. So next, coming to gastric carcinoma. So the fifth clinical is gastric carcinoma, and it is more common in greater curvature. In greater curvature. And next thing is, there may be also chance of metastasis. So the metastasis chance is especially from thoracic duct to left supraclavicular lymph nodes, and left. This is also called as Troyer's sign. Troyer's sign. And these lymph nodes are also called as, that is, this left supraclavicular lymph nodes are also called as signal nodes, because they are giving signal for metastasis of gastric cancer. So finally, we have the common investigations of stomach. They are like chemical gastric analysis, that is a fractional test meal is done chiefly to estimate gastric acidity. So fractional test meal for estimating gastric acidity. Next, coming to radiological examination by means of barium meal, we have discussed already. After that, you will do skiagram. Next, coming to endoscopic, mainly by gastroscopy, interior of stomach can be scanned under direct vision, so that is endoscopy. Next, coming to pyloric obstruction, this can be congenital or acquired. So it causes visible peristalsis in epigastrium and vomiting after the meals. So this is pyloric obstruction, because pyloris obstruction means the food can't go into the intestine. So the food got stuck in the stomach, and there will be always vomiting after the meals, because the food is not going into the intestine. So by this, we have completed all the clinical anatomy, everything about stomach in just one video.